Good morning, everybody in Outpatient OT. So welcome, first of all, for all of our newcomers, welcome to physical medicine and neurological occupational therapy. Here we encourage using our full scope of practice in everything that we do, the full body, right? So using biomechanical, biopsychosocial model principles of kinesiology, like we're learning about in our class this coming Wednesday and every Wednesday throughout this semester, we are going to be really encouraging a different lens through which we see our patients. So today I'm popping in here. I know all of you are probably headed off to work. It's nice and early, and this is when I have time, and I wanted to come on here and address something that many of you are actually asking, which is treatment building. So how do we choose the right treatment for our patients? There's this unfortunate gap between academia and clinical practice. These are like two silos of thought. A lot of the times they're not overlapping. It's like you learn all of this stuff in its parts, but then we don't have enough time to actually translate it to how it's going to be when we get in front of somebody with this diagnosis. We were talking the other day about how we take multiple sclerosis, for example. We learn the disease process, we learn how to help somebody compensate and adapt in later stages of MS, but we never learn how to help somebody maintain or recover from an exacerbation. We never learn the remediation or restoration process for these diagnoses. And so by the time we get out into field work where they say, oh, you'll learn that on field work. Well, what happens when you don't? What happens when you have a stagnant clinical instructor who is not up to date with evidence-based practice? What happens when you head into field work and they just give that person cones or therapy or digiflex, a flex bar for no apparent reason because they're being seen for a hip replacement? What then? How do you adapt to that when you're not given the skills to actually practice occupational therapy, and instead you're given just these ideas of where occupational therapy could take you as a clinician? What happens is we forget that we can actually remediate function, and that we're charged with that. We're charged with that outcome. We're charged with the ability to remediate function and maximize someone's performance, occupational performance. We cannot just adapt and compensate. That is not an entire profession. That's just the rehabilitation model. That's the rehabilitation model of practice, right? That's one model. That's one framework. That adaptive compensatory lane, that's only one avenue of occupational therapy. You have to remember that there's so many more. There's the possibilities are endless, and that's why it's so important for you to know theory, frames of reference, different rehab models, right, or approaches. You have to know all of these things so that you know what can guide you, and that there is so much more than just compensations and adaptations. You cannot just jump right into wheelchair mobility. You cannot just jump right into an ADL. If you look at somebody coming in who has all of these needs, and all you see is, well, I can work on weight shifting or sitting with that person because that's all you learned in school, we have to remember that there's a whole world out there. So let's jump into it here. So treatment, what do we do when we're building a treatment plan? Number one, we learn the diagnosis. Whoever your patient is, whatever their diagnosis is, you are going to look up and you're going to research that diagnosis, because you cannot help them if you don't know their diagnosis, if you don't know the physiological healing response, if you don't know that physiological, all the alternatives to practice, if you don't know where you're going, how can you lead your patient into maximum return? So you're going to go home and you're going to research. with a new diagnosis. Everybody here researches like probably a couple hours, 2 to 3 hours when we have a new diagnosis so that we can know how to approach our treatments or our plan of care. After a evaluation, I need to let that set in. Before I can write someone's plan of care, I have to think about their actual diagnosis, where they're at, where they were, their prior level of function, where they're going. So once we have a plan of care, then we have to work on treatments. And whether you're an OTR or you're a COTA or an OT versus an OTA, you have to know and look up their diagnosis and the current research on that. Who's getting the best results and what can you bring to each treatment? The next thing is age appropriate. So this is really a big, it's my soapbox, I think. I think I'm gonna just take this soapbox around, and I'm gonna stand on it wherever I am. You have got to make sure that you are not going to Pinterest and just pulling down a pediatric activity and giving it to an adult. You can't do that. I heard somebody in SNF, and I used this example before, although I've heard it many times. Somebody was coming away from a group. The OT had gone in to the cafeteria to retrieve the patient, right, and bring them to OT. And they said, "Oh, see you later, guys. I have to go to my kindergartner class right now." Like, that's a huge problem. That's not funny. It's not funny that this person equates your treatment with kindergarten class. If that's the case, we're not doing our job. We cannot have someone joking about our profession. You have got to make sure that it's relevant and pertinent to their diagnosis, their occupational profile, so what's meaningful to them, relevant to what they want to work on. So if you, and we'll get to this in a second, but odds are, if you will work on this in EI or school-based with somebody in elementary school, if you present the same activity to like somebody who has, built the country on their back, or someone who's like gone through all of these ups and downs and is 65 years old, completely cognitively sound, and you're presenting this to them and calling it like skilled care, there's going to be some questions about that. So we can't do that. It's a dignity issue. It also makes people question the competency of their practitioner and ultimately the profession. So it has to be age appropriate, please. Next, we have medical and social science. Again, I have many friends who are activity leaders, many friends, actually many OTs have gone into being an activity leader. Activity leaders are not reimbursed by health insurance. They're not reimbursed by Medicare. They are not designated as a healthcare professional, nor do they have a they're not certified by NBCOT, and they are not an autonomous medical licensed state registered therapist. You are called to something different. You cannot just give someone a fun activity. You cannot play dress up. You cannot sit around and make arts and crafts. You can't do that. You are not allowed to do that. You are a medical professional. We are biopsychosocial occupational therapy combined in our history, right? Because we all learned that we combine history, we combine medical science with social science to meet the needs of the whole person. You cannot just choose a random activity and say, well, this is meaningful, this is fun, the patient will enjoy this, and therefore this is my treatment for today. It has got to be based in medical and social science. It has to be evidence-based practice. You have got to find some research on the lane of remediation you're choosing to embark down. You have to have support. If someone becomes injured, if something happens, God forbid, and you are sitting in front of litigation, for example, and they say, well, why did you do that with somebody? What were you doing? Or say insurance comes and you have a massive audit and they look at all of your notes, everything that you've done. Are they going like, what are they going to think? Are they going to pull back all of your reimbursement dollars because they're reading it and they're saying, what were you doing? Why couldn't they just go to the activity? Why couldn't they just go to activities for this? What are they seeing when they look at what you're doing? And if you're a patient, if you're treating a doctor, if you're treating another medical professional, how are you going to explain your treatment to them? You cannot just say, I pulled this from Pinterest. You have got to make sure that it's relevant to their occupational profile, relevant to their diagnosis and the physiological healing response of that diagnosis. And you have to make sure that it's based in either medical or social science or both, okay? Next is, how do we choose where to head? Isolate versus multimodal treatments. So there's two ways of building a treatment, right? You can either break it all the way down into its parts. Remember that transformative philosophy, right? We rebuild the rhythm. We're rebuilding the parts of the whole. We know that they're all integrated, and we know that there's many different factors that are affecting this person's course of recovery. So if we have an occupation that they are unable to achieve, let's just pull an ADL because everyone loves that. So let's say toileting. If this person is unable to walk, doesn't have grip strength, doesn't have more than 3 or 4 minutes of postural stability against gravity while standing, their sit-to-stands are, dependent. Say they're using a lift because they just don't have the sufficient muscle tone to perform such a huge action as a toileting transfer. If they have all of these things they have to work towards, then bringing them and just doing toileting over and over again isn't going to work, right? So you need to isolate the parts. You need to work on the lower body strengthening. You need to work on lower body coordination. You need to work on back postural muscles. So maybe a whole session, a whole 45-minute session, I'm working on maintaining posture because that's a neuromuscular component, right? So that takes repetition, that takes time, that takes patience, that takes a mindful treatment. So you can't be divided. You can't pull 5 different activities when you're working on postural support for the first time. Because if this person has some kind of neurological diagnosis, or in the neurological diagnosis umbrella, then they may not even know that they're like leaning or collapsing. So you're going to have to bring that mirror over to them for an entire session, and just hold against gravity so that their body remembers that it's supposed to support them in midline against gravity. You cannot just put the stickies on the mirror. You cannot just use your little your clothespins. You cannot immediately, you don't need to do all of that. In fact, you can't do that. You shouldn't do that. That's not evidence-based practice. If a person does not even have posture, static posture against gravity, you cannot immediately bring in the cones, bring in the cards, bring in your clothespins, because that person doesn't even have the motor planning to remain upright. So making it dynamic is against research. So just something to consider. So that's when we isolate the body and then we work in its parts. Then we shift into multimodal treatments when someone has the components, when someone has the structures and functions necessary to perform the basic body mechanics of a human being, like as a human anatomical structure. When someone has the basic components and are successful in those, at that point, we can start making it multimodal, which means we're addressing not only posture, we're addressing strength, we're addressing interhemispheric communication, we're addressing agility, fine motor, cognition, and dual tasking. We're addressing everything in one treatment. Now, those are amazing treatments. But we have to know that the patient has the building blocks before we progress forward. So knowing the difference between isolating and applying a multimodal treatment approach is important. And then finally, establish patient buy-in. Guys, you do not have the luxury to just say, hey, I'm OT and I'm here to help you. You don't have that luxury because nobody, unfortunately, and I hate saying this, but nobody is aware of our full scope of practice. You can't joke saying nobody knows what I do because it's not a joke. It's a medical profession, and that's a problem. Your patient has to know what OT is doing. It has to know what relevance it has on that person's life. So the first thing you're going to do when building a treatment plan is you're going to discuss what OT can bring to the table for that person without using the words functional, self-care, meaningful activities. Without using those 3 things, explain OT to them. Can you do it? Because people tune out. Their eyes glaze over when you say functional. They glaze over when you say self-care or ADLs. That means nothing. They want to move. They want to live. They want to get up and get going. They don't know what an occupation is, so don't say that. Can you explain your profession without using those words? That's my task to you. And then finally, when you come up with your treatment, sit down and talk to them. Hey, Mr. Smith, Mr. Jones, we're going to do this and this today. See what I have set up? This is what we're going to do today. How do you feel about that? Do you feel like this is going to benefit you? Do you feel like it's going to be harder or super easy? What are your thoughts? And that's how you start every treatment. Do you want to do something else? You ask them those questions for buy-in. And then if they say, I think let's do it. I think it's going to be really challenging and hard. And then we do it and it's not challenging at all. And then you have taught them how to be a little bit more insightful on their capabilities, right? Because we're psychosocial. So we need to have that perception-based piece in every treatment. So we have to make sure the client has buy-in with what we're doing. Okay, so that is that. Just a quick run through. We want to make sure that we learn the diagnosis before making a treatment plan. We want to make sure it's age appropriate. It's based in medical and social science and not just a random activity. The difference between isolating and using a multimodal treatment and when to use it, and then establishing patient buy-in. All right, have a great day. I will see you tomorrow in kinesiology, where we will be learning about the source of movement.